I love this discussion. You know, how long have you got it?
But that's what you tell your patients. So welcome to the next episode of Endoscopy Essentials, and welcome Rehan Haidry from London, now Cleveland Clinic in London, right?
That's right, yeah. Thomas, thank you so much for having me for this session. Really looking forward to it.
Our topic is, naturally, your name is associated with ablation of Barrett's esophagus, and I think that's a very interesting topic because when I think back, there were some attempts long time ago, a few decades ago, with argon beamer ablation, APC, and it wasn't so successful, and then came the resection guys, so the entirety of the Barrett was resected. And then how did ablation come back? Tell us a little bit about the history.
Well, it's interesting because with any type of ablation for Barrett's, the one thing that we've lacked historically is control. We found that now with RF ablation. I'm sure we'll talk about it later, but 2 or 3 decades ago, what we lacked was the ability to control ablation in the esophagus. Now, we know that Barrett's is a fraction of the patients that will get esophageal cancer, 10% maybe, but they're the only patients that you and I see, so they're the only patients we can target. And these guys, esophageal cancer it's a bad disease. The prognosis is poor, considering you look at the advances in all the other solid organ cancers in the last 2 decades. Esophageal cancer prognosis hasn't really changed. So the only thing we can focus on is Barrett's, and so Barrett's are the patients that we see. So historically, the notion that we could treat them with PPIs and somehow the Barrett's wouldn't progress, I think we've put that to bed now. It doesn't work. So we needed to do something to the Barrett's. And I'm sure you remember back to electrocoagulation and even PDT, which
was so painful.
Exactly, and it
everybody.
came, including the clinicians, and unfortunately for the patients with the strictures and the photosensitivity. And the reason was that there was no control in depth. The esophagus is such an unforgiving organ, and the Barrett's is just on that superficial 300-400 microns. And so be able to control ablations so that you don't go deeper and cause the scarring and the stricturing and ultimately the strictures that you and I know can be more problematic than treating the Barrett's. That was the unmet need. And so we meandered through different technologies from PDT to argon, and we've swung full circle now, because now the control that we wanted with argon back then has come back now because of the innovations in technology and catheter design. And now we then landed with radiofrequency ablation, and then we went away from heat and we started looking at cold, and now we're trying to decide which is best. And so it's a good problem to have. It's a good problem for the patients to have.
We have almost too many techniques, but
exactly.
The problem is stratifying.
Exactly.
So let's focus on radiofrequency ablation, because this is still the most published technique with the highest quality of evidence. Do you remember the start? Because you were involved very early, right?
I was. We were involved in London in shortly after the 2007 publication came, the AIM-1 study, and the benefit of RF ablation was that you had this pulsed electro pulsed energy that was uniform because of the electrodes. So the first study that came out of the US, and then we were involved in the UK in 2008, where we did the first case to UCH with my mentor then, Lawrence Lovett, and then I was instrumental in helping to set up the UK registry just as Europe was beginning to adopt it. And it was an exciting time, not just for us as clinicians, but for patients. We finally had a modality that showed promise, but we still weren't quite sure which patient to use it on, how to use it. And so when radiofrequency came along with Barrett, there were different catheter designs. There was a balloon catheter, a focal catheter, and very quickly we created an algorithm that is now universally accepted, that we would still resect everything that we see. That was something that we couldn't shy away from. Is ablation was not going to cure esophageal cancer. It was going to stop it from coming back, but resection was the key. We set up the UK registry in 2008, and we closed the 10-year follow-up, a few years ago. But over 1,000 patients later, just in the UK, we showed really good outcomes, not just in the short term, which is what our surgical colleagues were worried about, that, you'll just burn it away, but it will come back. But we showed actually in the long term, we stopped these patients from getting cancer. And, now with over 100,000 patients around the world, in Germany, in the US, in Europe, it is now the standard. Most societies endorse resection followed by ablation, with RF having the majority of evidence, which is really pleasing to finally have fulfilled that unmet need that we struggled to do so for such a long time.
That's right. So it's pretty established, but I still want to start from scratch. There's the Barrett patient, and you often, you surely see these patients as well. There's a young guy with a 3-centimeter Barrett. You do your stepwise biopsy, you look carefully, and there's nothing. It's just metaplastic Barrett. And the patient comes and say, "Can't you do anything, please? Can you?"
Yeah.
That's a difficult discussion. So, what do you say?
I love this discussion. How long have you got? It is the conundrum that we face, because we ultimately, what we're trying to do as clinicians is we're trying to mitigate the cancer risk. And in the same way that ablation technologies have evolved, the rate at which we thought these patients got cancer has gone down. So we used to think it was 4% per annum, and then all these population-based studies over the past 20 years, actually the risk of them getting cancer with just Barrett's metaplasia is negligible.
Yeah.
It's 0.2, 0.3%.
Yeah, per year and patient. Huh?
And so I think that then makes the decision-making that much more complex, because if you're a patient, because that's what it centers down to, the patient will go on the World Wide Web and put in Barrett's esophagus. The only thing they will think about is, I'm going to get cancer.
And everybody's frightened if he Googles Barrett's.
Exactly.
Yeah.
And so we then have to find a way of negotiating with them that actually, I can do the treatment for you, it's easy, but I don't know if I'm going to change the risk of you getting cancer. So I think in that young patient with 3 centimeters of Barrett's, which you and I and our colleagues see all the time, I think the take-home message is actually, you're not going to die of esophageal cancer if we do nothing. You're going to take cancer to your grave in 60 years from now. And what we can do, and where I think that the biggest advances in Barrett's will come in the next 5 years, is how we can find which of those patients we need to treat early. Is that risk prediction, risk stratification, that holy grail, that panel, whether it's a liquid biopsy, whether it's a genetic biological profile, that will differentiate that young man from a different patient where that risk is not the same. And they're the patients then we can do the treatment on, because that's not just cost efficient, and we have to think about this in our practice. If we open the floodgates, that's all you and I would do is just ablation, and the hospital would be broke. Is finding those patients, and I think that is where we need to go in the next 5-10 years.
It will be tough studies though, because you have all long term, and then you are ending up with a percentage of 1%, and you have to compare them with the rest. So it's such a valid point you make, because historically, you and I have stood up in lectures and said that acid reflux is the precursor to Barrett's esophagus and esophageal cancer. We know, it was a really elegant study from the US last year, showing that actually people without acid reflux also get Barrett's. So this dogma that actually reflux is the patient cohort we need to chase and look after, it's changed the goalposts a little bit. So I think it's to your point, is that what is that magic number that is a threshold between treating and surveillance? But Thomas, I think it goes back to, I know we're talking about ablation and therapy, but and forgive me if I'm digressing here slightly, but another unmet need in the Barrett's esophagus patient is the quality of the endoscopy that they get first up. I always say
and I was taught, is that your first endoscopy on a Barrett's patient is the most important
Yes.
one. And I've never forgotten that. Because we're blessed as endoscopists now. The scopes that we have, the endoscopes that we use, the technology that they've put into the CCDs and the post-processing, and now artificial intelligence is on our shoulder for every patient, is ultimately that young man with the 3 centimeters Barrett's, if he has dysplasia, then we have the tools now more often than not to find it. So I that's what I say to the patient, is if you've got it, we'll find it.
And it's also known that the majority of cancers sort of seemingly appears during the first follow-up, so we're missing a bit, and some come with the cancers, but still the majority is non-dysplastic Barrett's esophagus, and the message is not to treat them. Other than the patient is very demanding, but that's what you tell your patients. I can do it, but probably your risk is unaffected, and you cannot escape controls, because there is a long-term recurrence rate, at least of minimal Barrett's of 30 or to 50%, depending on the time of follow-up.
You're absolutely right. I mean, there are mitigating circumstances. The young man with a family history, a long segment of Barrett's, he's a smoker, he's slightly overweight. We know that all of those population-based factors will just increase that risk. So there the threshold drops slightly. But as you've articulated, we as gatekeepers for this technology have to make sure that we do have a funnel, because otherwise, the science goes out of the window, and then we're just doing homeopathy.
So everybody's waiting for the risk strategy.
Exactly. Yeah. No. So
if the risk is 20% instead of 1%, that's easy. But then, all these definitions start. What is a risk? But that's maybe an individual thing to discuss with a patient once we are able to tell his precise risk. Not a general risk of a Barrett population, but are you of the very few with a higher risk, et cetera, et cetera.
It will be a multimodal approach. Yeah. And then we will layer upon layer information that will define that ultimate risk. And because we're fortunate now that we have ablative technologies, we have endoscopic eradication therapies that are not just effective, but they're safe, and they're widely available now through, the training platforms that we set up in London in way back in the early 2010s, that you had also hosted in Hamburg. That helped to disseminate the learnings for ablation and resection, which are now widely practiced around the world, which is great, which is what we wanted to see.
No, absolutely. So we leave the truly metaplastic Barrett behind us.
Yes.
And we go to the dysplastic Barrett. So you have done a careful examination. I mean, the Barretts are so different, aren't they? There's the thick Barrett with the villi, the classical one. There's the atrophic Barrett. There's the totally irregular Barrett, which mostly comes back as normal as well. What's your approach to biopsy? Because there's this increasing image-obsessed approach saying, if I see nothing, there is nothing, and I don't do biopsies. To which of the religious groups you belong?
It's interesting when with the advent of enhanced imaging. I remember when narrowband imaging came out, and then there was an explosion in classifications in Barrett's, and then lots of studies were carried out on, when can we give up doing Seattle protocol biopsies, and for 5-6 years, publication after publication on classifications, and all from experts saying that, we can find dysplasia, but actually we can't. Dysplasia is difficult to find.
Thank you.
Barrett's is not like a colorectal polyp. You do a colonoscopy, it's there. You have a visual analog you can take off. Barrett's dysplasia, you have this mosaic pattern. So anyone that says to me that he or she can see all dysplasia, then first of all, congratulations, but I don't have those skills.
Okay,
and gosh, I've tried really hard, because it's tough. And so with all of the advances in endoscopic imaging and in computer-aided diagnostics, which we needed for the reasons that you said earlier, because we're still missing cancers after 1 year, whilst we have made those advances, we still don't know. And so we know that if you do Seattle protocol biopsies, you will still pick up dysplasia.
Yes, right.
It is better than doing nothing.
I think the issue is that all these studies come from referral centers where patients come pre-selected. So somebody else outside there has done the job mostly by biopsy, and then we know this is a patient with dysplasia. Whereas out there in the community, the general endoscopist has to scope, I don't know how many dozens of patients to find one dysplasia. So that's a totally, for imaging, which is highly subjective, it's a totally different scenario. And of course, if there is something, the likelihood that you will find it is higher than if you just don't know, and the likelihood is very low.
And I look back at some of those publications that we published 10 years ago on imaging, and I look back and I think, how did this get accepted? Because there was such an enriched population. It was us doing them. It's all we did. As you know, we had muscle memory. And so I look back now, and I'm not ashamed. I'm proud of the fact that they then got people to start thinking. But I don't know how they got accepted, because there was such an enriched population where we had sub-selected that type of patient.
Slight criticism towards editors, maybe.
Well, it's not a criticism. It's a reflection of how we have shaped our own practice and our guidance based on the information we have to hand. But I think what coming back to your point is it's tough, and so what we need to do is we need to continue training people to use all the tools they have available, and the easiest tools that we have available are time.
Yes,
and we forget about that in endoscopy. Is we've shown if we take time, we find more adenomas. The adenoma detection rate goes up and patients don't get colorectal cancer. So in Barrett's, I think the first thing is if you just take time, sedate your patients, take time. And if it's there, you'll find it. And if you don't find it, then take your biopsies. And now in the US, there's this big, the use of other sampling modalities. They have this brush, the Watts brush, the wide area, transepithelial sampling. So all of these adjuncts will help to find dysplasia, but it's tough to find in my hands.
Right. But let's assume we are at the center and a patient is coming with a diagnosis of dysplasia. I don't want to touch the problems of low grade, because there has to be a second opinion and blah, blah, blah. Let's maybe, for the sake of easiness, start with high grade. And then, of course, you do your endoscopy, and quite a few of them you find something, you can identify it, but in others not. So the question is stratification now, resection versus ablation in high-grade dysplasia, because there's a lot of data on ablation of high-grade dysplasia. Which is it really, the totally invisible one or the multiple one, or how do you stratify resection versus RFA?
I think this notion of invisible high-grade dysplasia has always not sat well with us as endoscopists. In fact, there's a really nice publication, I think, in GI endoscopy just within the last few months, showing that patients who had monotherapy with RFA for high-grade dysplasia at 10 years, they were the ones that had recurrence. Really elegant study. And the take-home message for us was, if you get a biopsy back with high-grade dysplasia and your pathologist who you're working with, intimately tells you this is high-grade dysplasia, then it's not cancer. There's no need to rush in and start ablating or resecting, because as you showed, where certainly in Germany it was such a resection-heavy strategy, which rightly so, was that actually a lot of these patients, when you resected the high-grade dysplasia, they had cancer. And the same way with esophagectomy specimens, when you resected the high-grade dysplasia, when they used to do esophagectomy, actually 60% of them had cancer.
Well,
so
the rate is probably lower, but we don't fully know.
But I think your message is, if they have high-grade dysplasia, I'd say 9 times out of 10, we'll be able to see something, whether it's a lesion or a nodule or an area of abnormality, and then they will need a resection. They will need an endoscopic resection, which not only will remove the visible abnormality, but will give us that risk stratification in terms of staging and depth of disease. And the work that yourself and the Dutch group have done in the last 5 years have helped just push those paradigms even further now. But that's the key, is coming back to basics, is resection for high-grade dysplasia initially, if it's visible.
At least try.
Exactly.
And visible is difficult, but so the threshold to start ablation with high grade is high.
It is, because we know if you do nothing, then these guys in 5 years, the risk of them getting invasive cancer is significantly higher.
So you look twice, and then what we do is to define the half of the circumference where we think it could be, and then start resecting. But then a substantial percentage, maybe minority, but still, then you don't have any. So it can be tough. That was my question. Is there the patient with high grade and you really see nothing, or it all looks the same? It's flat. Where you still do ablation?
Rarely now. In the past there was.
Less than 5%?
Less than 5%.
Okay.
I can think on one hand in the last 12 months where there's been that patient. There has been one. I remember, equivocally on back-to-back biopsies, there was high grade. I couldn't see anything. And so we ablated, and now we watch and we wait and hope that, I didn't miss a cancer. But those patients are rare. And I think those patients are rare because of those conversations that we're having with our pathologists, and the fact that we're doing more endoscopy and we're seeing things. But still, in that rare patient, ablation has been shown in the randomized control trial from Nicholas Shaheen's paper, is that half of those 64 patients had high-grade dysplasia. They had ablation and they did very well at 1 year, at 3 years, and 5 years. So it is a known intervention for patients with high grade.
So let's put it that way. It's a niche which has become smaller.
Correct.
And including the occasional patient with a long Barrett, multiple high grade, in almost all biopsies, where the alternative would be a circular resection, which is still problematic. It's getting better with new drugs, but would that be a candidate?
It
Flat
would.
Barrett's, multiple high grade.
So that's a rare patient.
Yes,
That is a rare patient. And I think that in your hands, a circumferential resection of a 10 centimeter segment of Barrett's is straightforward.
It's not a technical problem anymore. It's the stricture problem.
Exactly.
Yeah.
So because these patients, Thomas, are all asymptomatic, and then we do these things to them and they become symptomatic, and so then we have this dilemma that what was I treating in the first place, and so we have to make sure that we're weighing up that risk of intervention versus the risk of symptoms in an asymptomatic patient. So I think coming back to your point, it is a rare scenario, that multifocal high grade that you can't see. But I think in that case, with a patient-based discussion, ablation would still be an option.
Yeah. And we also know that you can do resections after ablation, after RFA.
Yeah.
Jacques Bergman has shown it even in one go, huh?
Exactly, and
for the initial efficacy assessment.
They did it in the same session,
Yes.
and they also had a publication where they did the endoscopic resection and then did the ablation in the same session around the area that they had resected, and the stricture rate was higher. But I think one of the learnings we all have that one patient that we remember where I wish I
more
had,
than others.
where I wish I had done, and that for me in my career so far has always been the most powerful learning. And I remember to this day, I hope you don't mind me sharing with you, is a gentleman. He would have been in his late 60s, early 70s, with cardiovascular disease, airways disease, low level chronic kidney disease, with a short segment of Barrett's. Had been surveying him with low-grade dysplasia, low-grade dysplasia, low-grade dysplasia. And one biopsy came back with high-grade dysplasia. And that was at the start of my career, so I was probably very trigger happy. And I thought, fantastic, he has high-grade dysplasia. And so, I bought him and I did a wonderful circumferential ablation. I was so happy, he looked beautiful. Anyway, I went on holiday a week later, and I remember I came back 6 weeks later and I heard that he'd had a very poor outcome. He got admitted with some hematemesis, went into renal failure, and unfortunately had a poor outcome afterwards. And, your first thoughts are to the poor family and the patients, because we always want to do well, but there was a period of deep reflection there, that what was I treating then? Was I treating the patient, or was I treating a biopsy result? And I was treating a biopsy result. So I think that whilst, we sit here and we're algorithmical about, we treat high grade or we treat, these patients often don't die of esophageal cancer because they come with a burden of other
and they die of other
disease. And so I still remember that patient, and it's helped me to reflect on my decision making. That yes, we as societies, we advocate that you must do this and must do this, but you have to often take it on a patient-by-patient basis. So sorry for sharing that with you, but
No, it's fine. I think it's a very nice conclusion to that session, because it shows there's over-treatment, as in this case, by ablation, but we always are more afraid of under-treatment.
Yes.
And this balance is very difficult, but we'll get to that in the next episode. Thank you very much, Rehan.
Thank you, Thomas.